Back again, I'm Alan Yu, Director of the Division of Nephrology and Hypertension and Jared Grantham Kidney Institute at the University of Kansas Medical Center. This is part 2 of electrolytes and acid-based practice for the boards. Here's my bio. I have no disclosures. And for this part, we're going to finish off the potassium disorders by talking about hyperkalemia and then discuss acid-based disturbances. And we're going to be doing that by going over a series of multiple choice questions that are written in an ABIM board style. So the first question is a case of a 41-year-old female with lupus nephritis and chronic renal insufficiency who's maintained on prednisone and candesartan and comes for a routine visit. Her blood pressure is 146/95. She has some edema, and her potassium is 6.3 with a creatinine of 1.6. Which of the following would not be appropriate in the management of this patient? Hydrochlorothiazide, discontinuing candesartan, spironolactone, low potassium diet, or potassium binding resin. And I think the answer is spironolactone. All of these other answers would definitely reduce potassium. So stepping back and just thinking systematically, when I approach a patient with hyperkalemia, the causes that I think of are increased intake, decreased urinary potassium excretion, or shift of potassium out of cells due to one of these conditions. Decreased urinary potassium excretion can be diagnosed if urinary potassium excretion is inappropriately low. In the boards, they usually would give you a 24-hour urine potassium, in which case a level of less than 40 would be considered inappropriate. The causes of decreased urinary potassium excretion are summarized here. Since potassium is secreted in the collecting duct, decreased flow of fluid to the tubules can reduce potassium excretion. And that can be either because the GFR is low or because the patient is volume depleted and pre-renal. In addition to that, secretion of potassium itself in the collecting duct, which is under the control of the renin, angiotensin, aldosterone system, can also be reduced. So this can occur because of adrenal insufficiency or because of medications that block the renin-angiotensin aldosterone system, which include nonsteroidal anti-inflammatory drugs, ACE inhibitors or angiotensin receptor blockers, heparin, spironolactone and related steroids, and calcineurin inhibitors. It can also occur because of block of the epithelial sodium channel ENaC, which reabsorbs sodium in the collecting duct in exchange for potassium secretion. And this is blocked by potassium-sparing diuretics like amiloride and antibiotics that mimic this action, like trimethoprim and pentamidine. And then finally, patients can have hyporeninemic hypoaldosteronism, a condition that's commonly associated with mild chronic kidney disease in association with diabetes or tubulointerstitial disorder. So this patient had multiple causes for hyperkalemia, reduced GFR, an angiotensin receptor blocker, and hyporeninemic hypoaldosteronism, most likely because of her lupus nephritis. Second case is a 48-year-old female who's evaluated for several weeks with fatigue, nausea, and mild generalized abdominal pain. And on exam, she's thin and tanned with a lowish blood pressure. Her palmar creases are hyperpigmented. She has a potassium of 6.1 and a serum glucose of 40. Which of the following tests would be most likely to establish the diagnosis? Plasma renin and aldosterone, serum cortisol at baseline and after ACTH, serum C-peptide, iothalamate GFR, or genetic testing of the sodium channel gene. And the answer is B, serum cortisol. So this patient, as you may have gathered, who is hyperkalemic, has all of the features of adrenal insufficiency, and the high potassium is because of reduced aldosterone level and reduced sodium reabsorption and potassium secretion. Next case is a 26-year-old male with AIDS who's admitted with pneumocystis pneumonia and treated with prednisone and intravenous trimethoprim sulfamethoxazole. On exam, vitals look fairly normal. He appears tachypnic with diffuse rales on his chest auscultation. EKG is normal, and his serum potassium is 5.6 with a normal creatinine. Which of the following would be the best treatment for the hyperkalemia in this patient? Is it fludrocortisone, sodium bicarbonate, discontinue the trimethoprim sulfur and start pentamidine, discontinue trimethoprim sulfur and start clindamycin primaquine, or none of the above? And the answer is, I think, D. So, as you may have gathered, the problem with this patient is the high-dose intravenous trimethoprim, which is an organic cation that acts like amiloride and benzamyl and blocks the epithelial sodium channel ENaC. Pentamidine does the same thing, so swapping trimethoprim for pentamidine will not help, but swapping it for clindamycin and primaquine, which don't do this, would solve this problem. And here's a reminder in graphic form of how this works. So here's a collecting duct epithelial cell. This is the luminal side, where there's delivery of sodium and fluid from the upstream segments. Sodium is reabsorbed through the epithelial sodium channel ENaC. This makes the lumen electrically negative and drives potassium secretion through the apical potassium channel ROMK. All of this is stimulated by the action of aldosterone on the mineralocorticoid receptor. Amiloride and triamterene block ENaC, but so do trimethoprim and pentamidine. And so, because sodium is not reabsorbed, potassium cannot be secreted. Next case is a 57-year-old female with end-stage renal disease secondary to diabetic nephropathy who's maintained on chronic hemodialysis and seen on a non-dialysis day. And her serum potassium is 7.1 with a serum creatinine of 4.5. And the question is about therapy. All of the following would lower the serum potassium substantially except insulin and glucose, sodium bicarbonate, albuterol, sodium zirconium silicate, hemodialysis. And the answer is sodium bicarbonate. So when we treat hyperkalemia, if needed, the first step is to stabilize cardiac membrane excitability with calcium chloride or calcium gluconate intravenously. The next fastest step is to increase potassium entry into cells. There are 3 medications that can potentially do this. Insulin and glucose, which are very effective. Beta-2 adrenergic agonists, primarily albuterol, given at 2 to 4 times the doses that are used for asthma and COPD, and sodium bicarbonate, which should shift potassium into cells in exchange for protons. However, sodium bicarbonate does not work well in end-stage renal disease patients, and that's been empirically shown. Finally, you can remove potassium from the body, which is the more permanent solution, either with a cation exchange resin, with diuretics, or with dialysis. And here's the citation to the study that's, almost 30 years, or over 30 years old now, where patients with hyperkalemia on dialysis were treated with insulin glucose albuterol or epinephrine nebulized sodium bicarbonate in hemodialysis. And 3 of these lowered the serum potassium, but sodium bicarbonate was ineffective. Our last hypokalemia case is a 23-year-old male with diabetes mellitus who presents with 5 days of polyuria, polydipsia, and abdominal pain. He has a potassium of 6.5, a bicarb of 15, glucose of 296. Urinalysis is as shown. Which of the following statements about the total body stores in this patient is most likely to be correct? Is the patient total body potassium depleted, total body potassium overloaded, normal potassium stores but redistributed to the extracellular space, normal stores redistributed to the intracellular space, or none of the above? And the answer is actually total body potassium depleted. So this, as you gathered, is a patient with a case of diabetic ketoacidosis. So insulin, as you recall, shifts potassium into cells. So in diabetic crises, potassium is shifted from the intracellular to the extracellular compartments. Remember, these patients also have osmotic diuresis. As they excrete glucose and free water, that higher potassium concentration in extracellular fluid leads to greater potassium losses. And as a consequence of that, these patients become potassium depleted, but this profound potassium depletion is masked by this shift of potassium out of cells so that they appear to have hyperkalemia. Treatment with insulin shifts the potassium back into cells and unmasks a profound hypokalemia, which is why aggressive repletion of potassium is part of the mainstay of treatment of diabetic ketoacidosis. Okay, let's move on to acid-base disorders now. An 18-year-old female is brought in after a suspected suicidal attempt. Unidentified pills were found in her pocket, and she's obtunded. She has a heart rate of 112, a respiratory rate of 30, temperature of 101.8, and the labs are notable for a bicarbonate of 15, pH of 7.35, and PCO2 of 25. Sometimes it takes a while to work through these acid-base disorders, so if you want to pause the video and work through this, that would be a good idea. Question is going to be, which of the following is most likely to be helpful in this patient? Forced alkaline diuresis, intravenous ethanol, insulin drip, glucagon, or potassium citrate? And the answer is forced alkaline diuresis. So here's how I would work through it. Firstly, the pH is 7.35, so this is an acidemia. The bicarbonate is 15, so it's a metabolic acidosis. The PCO2 is 25, and what we expect from compensation, which we use Winter's formula, is 1.5 times the bicarb plus 8, and that equals 30. So this patient's PCO2 is also low, so this is a primary metabolic acidosis and respiratory alkalosis. If we look at the anion gap, sodium minus the potassium and bicarb is 26. The delta-delta is as follows. Normal anion gap is 10, so the delta anion gap is 26 minus 10, which is 16. Normal bicarb is about 24. This bicarb is 15, so the delta bicarb is about 9. So the delta-delta is 16 divided by 9, which is a little bit less than 2, which is elevated. So most likely there is a superimposed metabolic alkalosis. And so we have, in essence, a triple acid-base disorder. Combine that with the fact that the patient's febrile, tachycardic, and tachypnic, and had a probable drug overdose. And this is the perfect picture for salicylate poisoning, for which the treatment is alkaline diuresis to trap the salicylate in the tubule and hemodialysis. And this is a slide to just remind you that salicylate is a weak acid in acidic urine. It's protonated, and so it is readily reabsorbed from the renal tubular lumen by non-ionic diffusion. But alkalinizing of the urine makes the salicylate anion deprotonated and charged and traps in the tubular lumen, enhancing excretion. Our next case is a 29-year-old female who's found unconscious and brought into the ER. And she's comatose and has an alcoholic fetor. Sodium is 129, potassium 3.4, bicarb 11, creatinine 1.6, glucose 72, lactate 1, osmolality is 300, and the rest of the labs are as shown. The most appropriate first step in the management of this patient is forced alkaline diuresis, dopamine, fomepizole, thiamine, hemodialysis. And the answer is fomepizole. This is why. So this patient has a metabolic acidosis. Using Winter's formula, we see that the PCO2 is exactly what we'd expect. So this is a pure metabolic acidosis. The anion gap is elevated, and the delta-delta is 1.1. So this is a pure anion gap acidosis. We'll notice that the serum osmolality is elevated, but is this appropriate? So we determine the osmolar gap, which is the difference between measured and calculated serum osmolality. Calculated serum osmolality, 2 times the sodium of 129, glucose in mg per deciliter divided by 18, BUN in mg per deciliter divided by 2.8, which I calculate comes to 266. Patient's osmolality when measured was 300, so there's an osmolar gap of 34, which is markedly abnormal. In the differential diagnosis of intoxications, a high anion gap and osmolar gap can be caused by ethanol, ethylene glycol, propylene glycol, and methanol. Propylene glycol only occurs in inpatients given IV meds, and there was no evidence that this was alcoholic ketoacidosis, so it suggests one of the toxic alcohols, ethylene glycol or methanol. Both of these are metabolized by alcohol dehydrogenase to toxic metabolites, ethylene glycol to glycolic acid, glycoxylic acid and oxalic acid, and methanol to formic acid. And so the first step in treatment of this is to inhibit alcohol dehydrogenase, either with the specific drug fomepizole or the less specific ethanol. Next case, a 78-year-old female has been in the ICU for 2 weeks because of cholecystitis, gram-negative sepsis, hypotension, and ARDS requiring mechanical ventilation. A renal consult is called because of a persistently low serum bicarbonate, and her medications include imipenem, acetaminophen, dopamine, and noradrenaline. And you can see that the bicarb here is 18. Creatinine is just a little elevated, lactate is 1.6, pH 7.27, PCO2 41. Which of the following are appropriate in the management of this patient's acid-base disturbance? CAT scan to rule out ischemic bowel, discontinue acetaminophen, add colistin to cover carbapenem-resistant enterobacteriaceae, alkaline diuresis, or ANC. And the answer is discontinue acetaminophen. So if we work through this, you can see that the patient had a metabolic acidosis and a little bit of a respiratory acidosis as well. The metabolic acidosis part is a pure anion gap acidosis. The delta-delta is about 1. And you may notice that the patient was on acetaminophen. So this is pyroglutamic acidemia, also known as 5-oxoprolinemia. The majority of these cases are female, they're critically ill or malnourished. The main risk factor is treatment of acetaminophen. All of these patients have an anion gap acidosis, and if you were to measure blood or urine pyroglutamic acid, it would be elevated. And there's not really much you need to do in terms of treatment other than stopping the acetaminophen and supportive care. But the important thing is to rule out other causes. And some of the other causes I mentioned, like sepsis and ischemic bowel, would cause a lactic acidosis, but this patient didn't have a lactic acidosis. If you're in a lab that measures lactic acid in millimoles per liter, then the number of millimoles per liter of lactic acid that you measure should be equal to its contribution to the anion gap. So here, where the lactic acid was about 1 to 2, it can only explain 1 to 2 of the anion gap. And so that would not explain this patient's severe anion gap acidosis. And this is just an explanation from a recent review by Mike Emmett of how acetaminophen causes pyroglutamic acidemia, that I won't go into, but I do discuss in my actual talk on acidosis. Next case, a 65-year-old woman develops a staph infection of a prosthetic knee and is treated with vancomycin. She developed vancomycin-resistant enterococcus and was switched to linezolid and treated for 6 weeks. She's admitted for nausea, vomiting, and abdominal discomfort, and was found to have a bicarbonate of 14, creatinine of 1.7, glucose of 74, lactate of 8.5, AST and ALT are normal, pH is 7.3, PCO2 29. What is the most likely cause of the acid-base disturbance? Is it seizure, drug-induced lactic acidosis, ischemic bowel, occult sepsis, or D-lactic acidosis? And the answer is probably B, drug-induced lactic acidosis. So lactic acidosis can be divided into 2 types, type A, which is associated with reduced tissue perfusion, and type B, which is the set of conditions that are not associated with impaired tissue oxygenation. The differential diagnosis: seizures, malignancy, liver failure, thiamine and riboflavin deficiency, and various drugs and toxins, on the list of which is linezolid, quite commonly, isoniazid, metformin, of course, and some non-nucleoside reverse transcriptase inhibitors. So this patient probably had linezolid-induced lactic acidosis. Remember, if the lactic acid concentration is reported in millimoles per liter, that can be immediately equated to its contribution to the anion gap and the lowered bicarbonate. So in this case, the lactic acid level was 8.5 millimoles per liter. It would contribute 8.5 to the anion gap, which was most of it. So this was a true lactic acidosis. Next case, a 28-year-old Asian female with a photosensitive erythematous malar rash and arthralgias is referred to renal clinic because of abnormal lab electrolyte values. She denies vomiting or diarrhea, does not drink alcohol, does not use laxatives or recreational drugs. Her K is 3.2, bicarb is 15. Urine lights are as follows. The most appropriate management of this patient is loperamide, hydrochlorothiazide, calcium carbonate 1250 milligrams a day, potassium citrate 1 to 3 milliequivalents per kilo per day, or sodium bicarbonate 5 to 15 milliequivalents per kilo per day. And the answer is probably D, potassium citrate, 1 to 3 milliequivalents per kilo per day. So working through the numbers, you will see that this patient had a non-GAP metabolic acidosis. The causes of this are either lower GI bicarbonate loss, in other words, diarrhea or lower GI fistulas, renal tubular acidosis, these two are the most common, a dilutional acidosis from treatment with large volume resuscitation of normal saline, a urinary diversion, or just recall that compensation, metabolic compensation for respiratory alkalosis can also be non-GAP and mimic a non-GAP metabolic acidosis. So in this case, the differential is diarrhea and renal tubular acidosis. I find it helpful to start with the urine anion gap. In diarrhea, the urine anion gap should be negative. With a renal tubular acidosis, it should be positive, either because of impaired ammonium excretion or because of excess urinary bicarbonate. This patient's urinary anion gap, which is sodium plus potassium minus chloride, was positive at 26, and so this indicates the patient had a renal tubular acidosis. In the differential diagnosis, you can see that the serum potassium is helpful. It's high only in the type 4 distal RTA. Urine anion gap, as I said, negative with diarrhea, positive in the distal RTA. Usually positive for proximal RTA, but it's variable depending on the stage of the RTA. Urine pH is not that helpful because it's variable in diarrhea, except that it's always inappropriately elevated in a type 1 distal RTA. So in these conditions, the patient's collecting duct is unable to secrete hydrogen ions and lower the urine pH. Therefore, the urine pH is inappropriately high, meaning greater than 5.5. In contrast, in a type 4 renal tubular acidosis, the ability to acidify urine is preserved. The problem is the inability to generate and excrete ammonia. So the urine anion gap is inappropriately positive, but the urine pH is appropriately low. Proximal RTAs on their own are challenging to diagnose, but fortunately in adults, it's almost always associated with other features of Fanconi syndrome, and in the boards that would probably be given to you too. And so that's a very important clue to proximal RTA. Here are some of the causes of proximal and distal RTAs. So this patient had an inappropriately elevated pH, an inappropriately positive urine anion gap, and hypokalemia, strongly suggestive of distal type 1 RTA, and the history would suggest that the patient might have lupus, which is, along with Sjogren's, the most common conditions associated with a type 1 RTA. The treatments for type 1 and type 2 RTAs are treatment with alkali, either bicarbonate or citrate. The major difference is that in a type 1 RTA, you're giving the alkali to neutralize the daily acid load, so 1 to 3 milliequivalents per kilo per day. In a proximal RTA, you're giving bicarbonate to replace the ongoing losses, which can be very large. So these patients can require massive amounts of bicarb, greater than 4 milliequivalents per kilo per day, and sometimes as much as 10. So a big difference there. The next case is a 54-year-old male with a 12-year history of type 2 diabetes, maintained on insulin, and proliferative diabetic retinopathy, and he's referred for proteinuria. He has a potassium of 6, a bicarb of 19, a creatinine of 1.6, and urinalysis shows 3+ proteinuria. The most likely cause of this patient's metabolic acidosis is diarrhea due to diabetic autonomic neuropathy, diabetic ketoacidosis, solvent abuse, type 1 RTA, or type 4 RTA. And the answer is E, a type 4 RCA. So this patient almost certainly has hyporeninemic hypoaldosteronism, which presents with hyperkalemia that's disproportionate to the level of GFR. Oftentimes they don't have an acidosis, but if they do, it's a type 4 renal tubular acidosis, meaning a non-gap metabolic acidosis with a positive urine anion gap and normal urine acidifying ability. It's frequently seen in patients with mild chronic kidney disease, and most often this is associated with diabetes and diabetic kidney disease, but it can occur with other conditions that affect the tubular interstitium predominantly, including lupus, obstructive uropathy, paraproteinemias, HIV nephropathy, and so on. And this condition can be mimicked by NSAID use, which inhibits prostaglandin synthesis and hence inhibits the release of renin. Next case is a 22-year-old male with HIV infection who started on heart therapy 3 months ago, and his meds are abacavir, tenofovir, and emtricitabine. And his labs have a number of abnormalities. The K is 3.4, bicarb is 18, phosphorus is 0.9, uric acid is 1.7, and the urinalysis and urine lights are as shown. The most likely cause of this patient's acid-base disturbance is HIV-related diarrhea, D-lactic acidosis, respiratory alkalosis with metabolic compensation, hepatic failure-associated renal tubular acidosis, or antiretroviral medication toxicity. And the answer is E, antiretroviral medication toxicity. So this patient has a non-gap metabolic acidosis. He has an inappropriately alkaline urine and hypokalemia. So this could be either a type 1 or a type 2 renal tubular acidosis. The clue is looking for features of Fanconi syndrome. So the patient one might look for renal phosphate wasting, for instance, by looking at the fractional excretion of phosphate. In this patient, it was 29%, normal was 5 to 15%, and the patient was profoundly hypophosphatemic, so definitely had phosphate wasting. Patient, you may have noticed, also had glycosuria, despite having normal glycemia, and the patient was hypouricemic. So these are all features of Fanconi syndrome. And if we look through the medications, we see a drug that commonly causes this, which is tenofovir. So acyclic nucleoside phosphonates, which include adefovir, cidofovir, and tenofovir, can all do this because they're all transported into proximal tubule by the same organic anion transporter. They can also cause acute kidney injury. It can be made worse if there are drug interactions or renal insufficiency because they're all renally excreted, and these can occur 3 weeks to 18 months after starting treatment. Moving on to metabolic alkalosis. So a 22-year-old female presents with polyuria, constipation, and fatigue. She denies taking any prescription or over-the-counter medications. Her blood pressure is 96/54. Exam shows only mild bilateral parotid enlargement, and her potassium is 2.9, serum bicarb is 38, and her urine lights are as shown. What is the most likely cause of this patient's hypokalemia and alkalosis? Is it Liddle syndrome, Gilman syndrome, Conn syndrome, diuretic abuse, or bulimia? And the answer is E, bulimia. So this figure is to remind you that in patients who are alkalotic And as an example of this, we give an example of vomiting, that the urine sodium can vary tremendously. So early in vomiting, the urine sodium is high. Why is that? Because sodium is excreted with bicarbonate to try and correct the alkalemia, and the urine is appropriately alkaline. As the patient becomes volume depleted, the priority becomes to defend extracellular volume, and so urine sodium drops. Consequently, they can't excrete bicarbonate, bicarbonate drops, and there's paradoxical aciduria. Throughout this, the urine chloride remains low, and so urine chloride is the best diagnostic indicator of extrarenal volume loss leading to volume depletion. And so that's why we use urine chloride in patients with metabolic alkalosis. So when we have a patient with metabolic alkalosis without a good explanation, first question is, are they hypertensive? In which case, it's a form of hyperaldosteronism. If not, I look at the urine chloride. If it's inappropriately low, patients usually have surreptitious vomiting. If the urine chloride is high, it's usually either diuretic abuse or Barter's or Gittleman syndrome. So in this patient, the urine chloride was profoundly low, and the patient had a low blood pressure, so it suggests that the patient was surreptitiously vomiting. Next case, a 31-year-old male with a several-month history of acid reflux and heartburn was admitted with nausea, vomiting, abdominal pain, and confusion. He avoids seeing doctors and takes only over-the-counter medications, which include ibuprofen, omeprazole, calcium carbonate, and sodium bicarbonate. On exam, he appears dehydrated and his abdomen is mildly tender. He has a bicarbonate of 38, calcium of 12.1, albumin of 4.5. The most likely diagnosis in this patient is vomiting-induced metabolic alkalosis, hyporeninemic hypoaldosteronism, primary hyperparathyroidism, milk alkali syndrome, or acute pancreatitis. And the answer is this is milk alkali syndrome. So milk alkali syndrome describes the combination of a metabolic alkalosis with hypercalcemia and acute kidney injury. Nowadays, it's not usually due to milk, it's most commonly due to ingestion of calcium carbonate from antacids. And it occurs because of the synergistic effects of alkalosis, which inhibits renal calcium excretion, hypercalcemia, which inhibits renal bicarbonate excretion, and hypercalcemia also causing acute kidney injury. And then the reduced GFR, which inhibits both calcium and bicarbonate excretion. So there is a positive feedback mechanism which drives this vicious cycle to make acute kidney injury, alkalosis, and hypercalcemia extremely severe. Here's our last case. A 54-year-old smoker with chronic obstructive pulmonary disease, diabetes, and CKD is admitted with pneumonia. Overnight, he becomes progressively more obtunded. Arterial blood gas shows a PCO2 of 78, so he's intubated and mechanically ventilated. 3 days later, a renal consult is called because of persistent alkalemia and failure to wean from the ventilator. And at that point, the serum bicarb is 43, serum creatinine is 2.4, pH 7.64, PCO2 of 41. Which of the following would correct the metabolic alkalosis in this patient? Is it acetazolamide, intravenous saline, hemodialysis, arginine hydrochloride, or all of the above? And the answer is all of the above. So this is a case of post-hypercapnic alkalosis. So in patients that have chronic CO2 retention, they also have compensatory renal bicarbonate retention, and that's normal. When such patients become acutely mechanically ventilated, This normalizes their PCO2 while their bicarb remains high, and therefore they become sometimes profoundly alkalemic. Now, this can correct over time. So the normal response of the kidney at that point would be to excrete the bicarb and return the pH as far as possible towards normal. But excretion of this excess bicarbonate requires three things. It requires time, days usually. It requires adequate kidney function. Patients with low GFR can't excrete it. And it requires euvolemia. Hypovolemia induces the renal tubule to hang on to sodium with bicarbonate and inhibits bicarbonate excretion. So in this particular patient, the problem was that the patient already had reduced kidney function and also was probably hypovolemic. So the first treatment for this is usually to attempt to resuscitate volume with saline, and then, if need be, to give acidifying agents like arginine hydrochloride. Some people give hydrochloric acid. Acetazolamide can increase bicarbonate excretion, but only if the kidney function is good, and hemodialysis will certainly work if the renal function is poor enough. And with that, I think we finished all our questions. Thank you so much for your attention, and good luck.